myself, Dr. Gunjan Goswami, Joint Secretary, MP Chapter IFS, on behalf of MP Chapter IFS and Rewa Obs and Gynae Society. With association with Rewa Obs and Gynae Society, I am Dr. Gunjan Goswami and Dr. Padma Shukla ma'am. We both are organizing a webinar, SIG endoscopy under MP Chapter IFS. So now I would like to introduce Dr. Padma Shukla ma'am. Padma Shukla ma'am is senior professor in Government Medical College, Rewa, and currently she is secretary in Rewa Obs Gynae Society, Foxy. Welcome, Padma ma'am. She has more than 10 publications in national and international journals, and she has been written many chapters in different books. And she is very dedicated to her work, and special area of interest are high-risk pregnancies, vaginal surgeries, gynae endoscopy, and preventive oncology. Now, Padma ma'am, would you please invite Dr. Punita Bharadwaj ma'am for welcome address and for introduction of SIG endoscopy.
Good evening, everyone. Good evening, Madam Punita ma'am. Ma'am, on the behalf of Rewa Obstetrics and Gynaecology Society, I invite you for your introduction of the IFS and for
SIG endoscopy.
SIG endoscopy. Madam Punita Bharadwaj madam is unit in charge and senior consultant gynecology.
Hello.
Endoscopy.
Hello.
Hello, ma'am. Good evening, ma'am.
Hello.
Hello, you are audible, ma'am.
Yes, can you hear me?
Yes,
yes, ma'am.
Good evening, everyone. I bring greetings from IFS. I think Rewa Society must have worked very hard for this conference, and I appreciate the hard work behind it. And before we start the webinar, I think I would invite you all to the IFS annual conference in Hyderabad from 9 to the 11th. You are all most welcome, and there is a package for everyone, the beginners and the masters. And I think we should start with the academic session. IFS is holding such webinars at frequent intervals involving the local people, which is a very great idea, I think. It involves all the endoscopists and infertility specialists from basics to the people who are doing advanced work. Let's start with this hysteroscopic webinar. Over to the organizers. Thank you very much for having us.
Thank you, ma'am. Thank you. So now, without wasting time, we will start our first session. So I would like to invite our chairpersons for session 1. Our chairperson is our respected Shalbala Srivastava ma'am. She is currently president of Rewa Obs and Gynae Society, and she is working. She has been working since more than 35 years in the field of Obs and Gynae Society, and currently running Gynaeshwari Nursing Home and Endoscopy Center in Rewa for public welfare. She did her MBBS and post-graduation from our Rewa Medical College. So welcome, Shalbala ma'am.
Thank you, Dr. Gunjan.
Thank you, ma'am. Our next chairperson is respected Prachi Sagar ma'am. Prachi Sagar ma'am is director of Sagar Nursing Home, and her qualifications are MD Obstetrics and Gynaecology from SS Medical College, Rewa, and her interest is leadership quality and management skills, and she has been working in her own nursing home since last 25 years. Welcome, Prachi Sagar ma'am.
Good evening, Dr. Gunjan.
Now, our next chairperson is my dear friend, Dr. Richa Chaurasia. Hello, Richa. Dr. Richa Chaurasia did her MBBS from Medical College, Ranchi, and her DZO from MGM College, Jamshedpur, Jharkhand, and did fellowship in from Tata Men's Hospital, Jamshedpur. Hello, Richa. Welcome, Richa. So now we will start our first session. Our first speaker is none other than Dr. Priya Bhavi Chitrava ma'am, who doesn't need any introduction. She is a very good teacher, mentor, guide, and very supportive to her juniors. And she is at present consultant and head of the Department of Reproductive Medicine, Bansal Hospital. But because of some unavoidable circumstances, she won't able to present talk, and on her behalf, Dr. Rana Mandal will give the talk. So I would like to invite Dr. Rana Mandal. Hello, Dr. Rana. Dr. Rana Mandal has many degrees. He is doctor, specialist in obs and gynae infertility. Did his MD, DNB, MRCOG, MRCPI, EFOG, EBCOG. So welcome, Dr. Rana. Hello. Dr. Rana. Mr. Makhan.
Yes, we can hear you, ma'am.
Okay. So our first topic is how to set up theater for hysteroscopic surgeries and detail in instrumentation and distension medium by Dr. Rana. Please connect Dr. Rana. Please connect Dr. Rana. Hello, Dr. Rana, please.
Call Dr. Rana. You are muted, Dr. Gunjan.
Some technical problem, ma'am. Wait for some time.
Okay.
बंद दबाव के काम नहीं होता
Welcome, Dr. Rana.
Yeah, good evening, everyone. Am I audible to everyone?
Yes, yes,
Yeah, and you can see my screen also.
yes.
Uh, Thank you for this wonderful series of endoscopy organized by IFS and SIG. Uh, Dr. Priya was unable to attend for unforeseen reason, and she won't leave at moment. So I just want to do the talk for her. That is hysteroscopy. On hysteroscopy, the theater setup, instruments required for it, and the distension media. So basically, this talks will cover the learning objective of this is what are the basic indications of the hysteroscopy, what are the theater setups is as, what are the ergonomics of it, and the instruments required for the hysteroscopy and the type of hysteroscopy and the newer nomenclatures, what are the available, and the distinction regarding some important points about the distension media and which distension media to which surgery and the energy sources and what are the complications can happen. So basically, hysteroscopy was started since the 18th century by the Desmoulins. It was because when she was doing the hysteroscopy, unfortunately put the cystoscope inside the hysteroscope, and from that the hysteroscopy was originated. First optical hysteroscopy was done by the Charles David, and then the first operative hysteroscopy was done by the Newitt and Emmy in 1976. The basic indications of hysteroscopy are basically what in our practice we mainly do to look for the before IVF. We need to evaluate the uterus, whether it is normal or not, any morphological abnormality present or not, how is the endometrium looks. Is this a main indication in our practice? But other than that, it is other indications are abnormal uterine bleeding, history of recurrent pregnancy lots, written product of conceptions, or any cases of surgery in myomectomy or interceptor resections, or we can also do recannulation and sterilization operations also. Now, this is the operative setup we use. The patient where the patient lies, and between the legs the surgeon sits, and the operative trolley is usually behind or around his or her, and the monitor is usually around here. This is usually we use the setup, and this is the basic setup is required for the hysteroscopy. But the ideal setup should be like this one, where the operating surgeon sits here and the patient lies over here, and the surgeon can view the monitor over here also. So directly can visualize it at 90-degree position, where the assistants and anesthetists can also observe these two monitors for their purpose. Also, this is a good ergonomic system, and it should be used for the also even for the laparoscopic also for major surgeries also. This is the ideal ergonomic system. Now, what with the basic requirement for the hysteroscopy are that we need to have obviously hysteroscope with a good working camera and light source and monitor. And it is better to have a video printer or digital printer, so we can provide the images of the hysteroscopy findings. As we in our hospital, we provide through a pen drive of the recording. Other than this, the systems are where in the foreign countries where they provide the patient portfolio on online, and they can go to the log into the portfolio, and they can also see their operative video on their portfolio also. So electronic cloud monitoring cloud facilities are very highly recommended. Now, this is what are the basic instruments required for the hysteroscopy. These are the basic instrument. This is the basic trolley we require for the hysteroscopic setup. That is a hysteroscope, hysterojet that is for the fluid to come, and the light source and the camera. And these are the instruments are often not required but need to have, because we mostly do a vaginoscopy approach, and the speculum and the dilator are required if it is in case of difficulty or need to hold the cervix in that case. Usually, this is a sterilized pack comes in our hospital like this. So where the sheath and scissor is usually better to keep even for the diagnostic hysteroscopy in case you require for it. These are the basic instruments need to have for operative hysteroscopy. And this is a resectoscope. This is a biopsy forceps to hold the polyp or anything. So cold knife or scissor is very useful to remove the adhesion, for polypectomy, even for the myomectomy, for septal resection. Punch forceps are useful for the biopsy purposes, also like in case of endometrial hyperplasia. Tenaculum and tenaculum spikes are required to hold the cervix or to remove the myoma after the excision. Myoma fixation to the palpation probes are like this. Now, basically we have two types of hysteroscope: rigid hysteroscope and the flexible hysteroscope. Rigid hysteroscope are like this. They can be 0 degree, 12 degree, and 30 degree, and 7 degree. Usually in our practice, and most of the gynecologists use the 30-degree hysteroscope. As by here you can see, by just rotating the cable, we can visualize the both ostia, and does not require to move. Like in these cases, 0 degree, you need to move the hysteroscope too much. There are types of hysteroscopy. These types are hysteroscopy available: pathology, compact hysteroscopy, and the semi-rigid hysteroscopy. Now, these are the newer ambulatory hysteroscope are also available, where you can handheld machine, you can see the monitor, and also you can attach to it your laptop and see, or even your smartphone also. These are software also used. Lina is very much dominant in this newer ambulatory hysteroscope. Now the diagnostic sheet and operative sheets are here. In operative sheet, there is only an extra channel is here to provide the instrument. In here, you usually find the inflow, and one is the outflow source, and the operating channel is like this. Another sheet is present. Sorry. So in here you can see this diagram. The operating sheet is for another for the light and for the instrument to purpose, and it is for the inflow purpose, and it is for the camera. Now, when to do hysteroscope, basically is preferable to do the first period of the menstrual cycle, where the polyphyletic phase, because it has a less cervical mucus and less resistance on isthmus, and also very less chance to have unexpected pregnancy. It is usually performed in a dorsal lithotomy position, and Trendelenburg position should be avoided for office hysteroscopy purpose. Prophylactic antibiotic is not required. Only painkiller is sufficient. Sometimes you can use the misoprostol to dilate the cervix also, but it's often not required. For the diagnostic hysteroscopy, we need to do a vaginoscopy approach. Hysteroscopy should hold around the isthmus and gradually towards the fundus, and rotate in the cable to see a panoramic view of the cavity. Now, before you proceed to hysteroscopy, this is a checklist should be having, that the consent should be taken, patient's ergonomics are in position, all the instruments should be available in what was the patient's last menstrual period, bladder should be evacuated, cleaning, draping position, and examination should be done to know the uterus anteverted or retroverted also. And this is a basic documentation we use in our practice to note the findings of the hysteroscopy. And if you find any pathology or polyp or septum, we can draw in here and to present it to the discharge summary. Now, in the diagnostic hysteroscopy, hysteroscopy is like we usually do like this in the vaginoscopy approach, where we enter the cervical canal, and according to the path we go through the cavity and rotate the cable. You can see here the rotation of the cable to see the both panoramic view of the cavity. Now, it is essential whenever performing the hysteroscope, it's not a blind procedure, so always have to be kept under the vision, and we need to like a path. That's it. Like when you're driving, you cannot drive under the under blind vision, so you need to follow the path. Like in this case, when long canal or T-shaped uterus, you need to follow the path. Even whenever the path you take need to under visual vision the cavity and go inside the cavity. This was a T-shaped uterus, needed to do a metroplasty, but with some difficulty. But you need to keep under always the vision and follow the path of the cavity. Now, in office hysteroscopy, first was proposed by the Vettoji, and 1996. It has some advantages like it reduces patient discomfort and high patient satisfaction rate. It can discharge patient on the same calendar day. Also can be done to the virgin woman to and was preserving the integrity of the hymen. These are the few common indications of the indication of hysteroscopy. In office hysteroscopy, we don't require vaginal speculum, tenaculum, or cervical dilatation, but it's often required to provide an analgesic and better, and often not required to prepare the cervix. But misoprostol can be used if you are suspecting to have difficulty. Now, this is a very important thing. A new consensus opinion and the nomenclature has been given by the AAGL and ESG guideline. These are the terminologies have been described. That is the pain management. They have described pain management level 1 to 5. They have divided settings into office, outpatient, and operating. They have provided a model of care and the type of the procedure and approach to the procedure also. Now they have provided this level of pain management level 1 and level 2. Level 1 is no medication, level 2 is local application of anesthetics only, level 3 is only oral or inhalation, and level 3B is parenteral medication as a sedative. Level 4 and 5 require anesthetic specialist and general anesthesia and general anesthesia. Usually for office hysteroscopy purpose, up to level 3A is administered. For outpatient hysteroscopy, level 3A up to 3A is also administered, but for operating hysteroscopy, level 3B to 5 is required. And these are the model of care they have been given for the hysteroscopy purpose. They have divided into 5. Office hysteroscopy, where they discharge the patient on the same calendar day and done in the practitioner professional premise, and the outpatient hysteroscopy done in OPD settings and discharge on the same calendar. The ambulatory practice, they have given this to done patient or hysteroscopy on a hospital or a surgical unit, dedicated unit, and discharge on the same calendar day. And extended recovery services are there where patient is admitted for some time, but it is less than 24 hours. And inpatient, as we have to say, when the patient is admitted more than the 24 hours. Now, it is important to note that these terminologies are not often applicable in our practice. This office hysteroscopy, outpatient hysteroscopy, and ambulatory hysteroscopy, these words are very much interchangeably usable in our practice and also overall the world also. Now, the type of the procedure, they have given diagnostic procedure to evaluate the uterus, and for operative hysteroscopy to perform any operations under the vision. Now they have divided the approach to hysteroscopy into vaginoscopy and speculum assisted according to the namely the how we are visualizing the cervix. If we are visualizing cervix directly through the operative hysteroscope, that is vaginoscopic approach, and if we are visualizing cervix with speculum, that is speculum assisted hysteroscopy. Now they have also proposed to this chart to note the how we are performing and what are the level of pain management we are providing. Now coming to the distension media, most of the distension media system we use this mostly used to have this pressure insufflator BP cuff, where it is this pressure insufflator is placed around the 100 centimeter above the patient's level, and usually 770 mmHg pressure required, and cup encloses around the back, and whenever to give the pressure comes through it and flow distension media flow into the cavity. Now these are the newer models. That is we mostly use these electronic devices where because it has a constant flow rate can be achieved, constant pressure can also be achieved. Also, it's better to keep the pressure around 150 mmHg, but if the situation demands, one can go up to the 250 mmHg also. Now here you can see in the storage machine what is the flow rate, the pressure, the suction here, and also suction pressure and the infusion. Here the irrigation system has been placed in a U-shaped manner, and this is the suction pressure device where the pressure is being put on the suction. Now this is the other various type of the available depending upon the markets. These are the commonly available hysterojet systems. Now basically this is the important thing. Some better to have an automated system, automated fluid management system, but if you cannot have automated fluid management system, you can calculate by yourself also. Here you can see this see over here that this is a infusion media placed on the pole, that canister is evaluated in the fluid and it goes back. And this is a resectoscope. Resectoscope's outer sheath, from outer sheaths, fluid goes outside, and here the weight has been placed. The fluid both here, how much fluid or weight has been in and weight has been out is seen. And if you minus both of it from this, you can get the net absorption, how much fluid has been absorbed by the patient. Now you can have both type of system. These are the Strauss system available in our. It's better to use, and both of the society recommends to use the automated fluid management system. That's because it gives more accurate result. This is the other fluid management systems device profile. Now coming to the distension media. No distension media is ideal distension media. Ideal distension should have this characteristic, but unfortunately there is no ideal distension media. Now coming to the distension media is available. Usually the gas media used to in past, but because of the risk of the embolism, it is not used. Dextran is also used in the past because of high allergic reaction. We mostly used a normal saline, that is electrolyte rich, or for operative purpose we can use glycine also. It is an electrolyte free solution. But it is important, the choice of distension media depends upon the procedure and the what instruments you are using. Now both of the distension media has some advantage and disadvantages. Like the electrolyte free solutions we can use a monopolar device, but it has can cause an excessive absorption of the fluid and leading to the hyponatremia, hypoammonia, and decreased serum osmolality can lead to the cerebral edema also. TRUSS syndromes also caused. Whereas in NS, if you're using, it is advantage is that it is readily available, inexpensive, isotonic, and no reaction, non-toxic, and and usually no allergic reaction happens to it. But it is also can cause this congestive cardiac failure and hyponatremia also. So it is also important to have careful monitoring. Now this AAGL has been recommended that for bipolar source, isotonic can be used, and for monopolar energy device, non-electrolyte media, hypotonic solution should be used. These are the energy devices available. These are the resectoscopes, bipolar or monopolar. These are the energy devices available. Depending upon your procedure, you should choose it. Now coming to the resectoscope here, you can see to have three sheaths over here. The inner sheath has a common sheath which contains a telescope, distension media, and the electrode. This is the electrode, telescope, and distension media from this inner sheath flows inside the cavity. And this is a middle sheath, and this is the outer sheath. Outer sheath has some holes from which distension media returns back to the distension container. Now, depending on the procedure, you can choose the loop you require, or you require a knife, if you require a roller ball or any other material. That according to that, you can choose the tip. Now, whenever the resectoscope you are using, it is very important to carefully handle the instrument. Hold with a non-dominant hand and put the telescope with your dominant hand until you heard the click sound, and then insert the electrode until you heard the click sound and properly fit. And it's better put the inner sheath, and better to check it right there so it is functioning or not, unless because if it is very disturbing, whenever you go into inside the cavity, it's fine, not working, that's kind of very disturbing, and it increases the operative time also. And also you need to have proper attachment of the light source cable and the camera head also. Now these are the fine instruments for the usually used for the like here for septal resection, roller ball for transcervical resection of the endometrium. You can use it for the fibroid resection also. Now the complication has been separated little, but I will discuss here the required for the fluid overload management, because it is actually the distension media. Now fluid overload is usually doesn't occur, but very rare, only 0.1 to 0.2% patients can suffer from this. It is very important to correct the hyponatremia at appropriate time. It is more than the 48 hours, the rapid correction is not recommended, but if it's less than 48 hours, rapid correction should be considered with and help of anesthetist. Now coming to these guidelines, what basically this guideline says is that the fluid deficit should be carefully calculated, especially if it is more than 1000 ml, and it should be monitored every 10 minutes interval. Here you can see the chart. The fluid intake output should be monitored. This should be done by the anesthetist, preferably every 10 minutes should be monitored, and review should be done in half an hour interval, and after 60 minutes the procedure should be stopped. Hysteroscopic operative surgery should not be done more than 60 minutes. Now, the factors that causes the fluid absorption are the retrograde passage to the fallopian tube through endometrium and through vessels and the sinuses, and it depends on the intrauterine pressure, mean arterial pressure, depth of the myometrial penetration, duration of the surgery, and the size of the cavity. So, those who will be the high risk, the high intrauterine distension pressure, low mean arterial pressure, deep myometrial penetration, prolonged surgery, those who have large uterine cavity are more likely to have higher systemic reabsorption. So these patients should be carefully monitored. The factors that has propensity for arising from the fluid overload are the osmolarity and distension media. It is important to recognize early. If you unrecognized and left untreated, it can lead to the bradycardia and hypertension, and pulmonary edema can develop and can be catastrophic sometimes also. Patient menopause, premenopausal women are high risk because estrogen has a suppressive effect of the ATPase pump. And patient cardiovascular system should be always checked. So it is important that complications are more common in a woman, hypotonic solution, electrolyte free solution, women at premenopausal status, and those who are cardiovascular renal compromised patients. Now, whenever the fluid is overload is more than the 1000, in cases of the hypotonic distension media, fluid restriction should be considered. And if the patient is asymptomatic and if the patient is symptomatic, the hypertonic solution can be given to the patient with supplementation of the oxygen and other supportive therapy. Now, to which patient, what is the threshold level to monitor? If the fluid deficient in a healthy woman, for healthy women, if it is hypotonic, it is 1000, and if it is isotonic solution, it is 2500 for NaCl. And if it is a renal and cardiovascular compromised patient, for hypotonic solution it is 750, and for isotonic solution it's a 1500 solution. The fluid deficit threshold should be agreed as anesthetist preoperatively, and it is always advised, especially in cases of the operative hysteroscopy. This French society has another definition. They use 2 liters for normal saline and 1 liter for hypotonic solution. Now, there is 2 methods to prevent the fluid absorption measures. One is use of GnRH analogs, another is a diluted vasopressin injection immediately before the cervical dilatation. These are 2 are the preoperative measures. There is a preoperative measure, and this can be considered in premenopausal women. Then this is recommended to comment, especially if you are removing the fibroid or any major surgeries you are considering. Intraoperatively, intraoperatively, it is essential to monitor the intrauterine pressure of the distension media and should be kept as low as possible and should be kept at below the mean arterial blood pressure. Now, monitoring should be done by the closed system. Drapes containing the fluid should be measured. It is recommended to have an automated fluid measurement system. It is more accurate, already discussed, and the measurement of the fluid deficit should be done at minimum 10-minute interval. Now, AAGL has recommended to, this is a BSG recommendation. AAGL has recommended to monitor it is a 15-minute interval. You can, depends, but you can choose according to your surgery also. Now, another important risk is air embolism. It is important to have patient never to put a patient in a tender lumbar position during hysteroscopy. Keep the pressure below the 100 mm. Minimize the need of the dilatation of the cervix, and also deep myometrial penetration should be avoided. Another important risk is the perforation. That midline perforation usually does not cause any consequences as the vascularity is more towards the lateral aspect of uterus, and lateral perforation can lead to hematoma also. Most common site of the perforation is the anterior wall, and which is often unrecognized also. When you can recognize the perforation, it is the loss of the uterine distension media, rapid decline of the pressure, rapid increase of the fluid deficient, sudden uterine bleeding. Now, the depends on the management. What is the nature of the perforation? Is it bleeding or not, and which instrument causing the perforation? Is it small perforation? Does not require anything other than conservative management. But in cases of the major or any lateral wall perforation should be checked by the laparoscopy, rule out bleeding and hematoma also. To prevent the perforation, one should see the pink myometrium whenever visible. Do not cut any longer because it can lead to the opening of the uterus wall. And whenever they're doing the septal resection or deep-seated ostia, it is better to do up till the when line joining the both ostia. Thank you everyone for patiently listening.
Thank you, Dr. Rana, for deliver a very elaborative lecture on instrumentation and introduction of hysteroscopy and OT setup. Thank you very much. Thank you.
Thank you.
So now I would like to invite our next speaker, Dr. Kuldeep Jain sir, but because of some dying emergency, he won't able to deliver his lecture live. So he recorded his lecture. Now we will play recording of his lecture. So Mr. Makan, please play recording of Dr. Kuldeep Jain sir's lecture. Dr. Kuldeep Jain sir.
Good evening, dear friends. This is my pleasure to be speaking on this platform, and it is my pleasure to be speaking on a subject which is very close to my heart. I will like to thank Dr. Punita, Dr. Priya, Dr. Mansi, and Dr. Gunjan for having me here on this very important endoscopy webinar. And I will be taking a very important discussion forward, art of negotiating the cavity. As you know that hysteroscopy is a very important tool in the hands of any infertile infertility consultant, because it provides direct visualization, and it provides an opportunity to correct the abnormality and see at that time and treat at the same time. It is actually very simple and relatively safe procedure, and always help in counseling the prognosis of the procedure just after the correction. Now, is it very difficult to do hysteroscopy? It is a simple procedure, but one has to learn the technique in correct way and how to optimize the use of hysteroscopy in your current practice. If you see this slide, it started looking at the cavity started in 1898, and now you can see how much has changed. We have moved to a very highly magnified view with the availability of various gadgets, various cameras, and now even you can see here that you can have a very thin hysteroscope, which is flexible also, and having a monitor attached on the hysteroscope only. So we have changed our perspective of doing hysteroscopy and its use in our day-to-day practice. Normally, in routine practice, rigid hysteroscope is used. However, the diameter is very important, because if you are having a diameter which is more than 5 millimeters, then it becomes very difficult negotiation in most of the cavity, because these females, they are nulliparous and you need to dilate. And when you are using a operative hysteroscope along, operative sheath along with this 5 millimeter or 4 millimeter hysteroscope, it becomes little difficult to negotiate the cavity without dilating. Now we are having very thin diameter hysteroscope, which can be used like 1.9 or 2.9 millimeter without any dilatation. And that is why one should be having correct knowledge correct piece of instrument before we start doing hysteroscopy. One has to know the basic anatomy before starting the hysteroscopy. Now, most of the hysteroscope, they are having 30-degree angle. So, when your angle is pointing upward, then you will be seeing the anterior wall of the cervix or anterior wall of the cavity. That you should know. And when you rotate by 90-degree, then you will be seeing either right side or left side. And when you rotate it by 90-degree, then you will be seeing the posterior wall. So this orientation has to be very, very clear when you are inserting, when you are negotiating through the cavity. Because if you don't know the angle or area, what is seen when you are entering, then it might be difficult and you may be entering into a false passage. Again, very important to know the anatomy. When you enter through the cervical canal, there is a typical appearance of cervical canal, and that you need to know, and where it is ending. Just after that, there is the internal os. So these are the crypts of liver cone, which can be very nicely seen, and they end within 5 millimeter of internal orifice. Many of the patients, they are having acutely anteverted uterus. Like in this case, you can see it is not a straight cavity. You have to negotiate the cavity by making a very sharp angle like this. So mapping of the uterine position and uterocervical angle is again very, very important in negotiating the cavity. These are some of the practical tips which one has to keep in mind. Always plan your hysteroscopy in postmenstrual phase. This is very important because that time the secretions in the cervical mucus and the cervical canal and the plausibility is very, very good. You will not be disturbing any unidentified pregnancy if you are doing it in postmenstrual phase. Cervical preparation is again very, very important because the nulliparous cervix, if you have not used any cervical preparation, it will be difficult to negotiate the cavity. Usually we use misoprost night before, and that is very, very helpful in making the cervical tissue soft. Always use small diameter, as I have already highlighted. You have to use a small diameter hysteroscope first before putting a operating channel, so you can visualize the cavity very, very clearly. A pre-procedural transvaginal sonography or hysterosalpingography is very, very important information which you should be having before you start the hysteroscopy, and that will tell you which angle is the cervical os is there, and many times the os is lying somewhere else on the either on the left side or right side, and you are not able to see the cavity, and you record it as a stenosis cervix. While it is not stenosis, it is the direction of the cervix which is having different anatomical position. In difficult cases, one can use a ultrasound guided negotiation, or it can be done under laparoscopic control. A good distension system is very, very important for any hystoscopic procedure, whether it is a diagnostic hystoscopy or a operative hystoscopy. Now, again, in all cases, you should keep bladder empty. Always do bimanual examination, so to know the mobility of the uterus, position of the uterus, and whether it is retroverted or anteverted. Always know your instrument, what instrument you are going to use. Smaller diameter operating sheath are also available, which whole instrument is less than 5 millimeter. And of course, there is no substitute for clinical acumen and experience. Now, what problems can occur during the negotiation of the hysteroscope? most of the time it is anatomical, but it could be pathological difficulty or a iatrogenic difficulty. And there are three sites where you can find the difficulty. One is just, it is a pinpoint external cervical orifice, or cervical canal is zigzag, or there is a problem at internal cervical orifice. This is a video of simple negotiation. We always prefer to distend the vagina. We don't use any speculum or dilatation. You see here, now you can see this is the distended vagina, and which we are seeing very clearly the anterior wall. You have to go around to locate the cervix. Now you can see the upper cervix, anterior lip, and then you can see the os. So once you see the os, you enter into the cervical canal. You can see very beautifully crypts of liver bone. This is the diagnostic of that you are in cervical canal, and you have to follow this black. You can see here, this you have to follow and keep it in center and go on entering into the cavity. It is very easy. Within 1 minute, you will be in the uterine cavity. This is a very simple case. That's why you are not required to negotiate much. But the position is not always like this. And here you see, use your distension media very powerfully. So here you can see this area. You don't see here the ostia till the distension is there. And as the distension increases, you can see the right ostia very beautifully. So you need not to do anything. Just keep your hysteroscope steady and do the distension. Rest of the thing will be visible. Then move from right side to left side. You have to visualize the left ostia, which is at the right angle to the other ostia. So here you can see in a straight line, and then the center of the uterus, that is fundus. So in one go, when you are entering, you will be seeing either the fundus or it will be on one side. So again, reposition your hysteroscope to visualize the rest of the cavity. As I told you, to see the right ostia, you have to rotate your hysteroscope on the right side and vice versa. And when you have seen right ostia and left ostia, then withdraw, have a very good panoramic view, come at the internal os, and now you can see whole cavity very beautifully. When you are withdrawing, again, withdraw very, very gently. So you can see the cervical canal again. If there is any small polyp or anything, you can again see. So there are less chances of missing anything when you are taking this approach. This is another video which is slightly difficult case. Again, start with the distension of the vagina. That is very, very important. This is called gynaecology. Gynaecology is just distending the vagina. You can see very beautifully. Here you can see the direction of the this os, external os, is pointing little downwards. So it means that uterus is anteverted. When the cervix is looking down, uterus will be anteverted, and when the cervix is looking up, uterus will be retroverted. So by just knowing the fact that it is cervical os is pointing downward, you can reposition your hysteroscope and just enter into the cervical canal. Again, you can see very beautifully the crypts of liver bone, blood vessels can be seen, and you have to follow this again. Now this is pointing towards going out of the field. So again, reposition your hysteroscope. Now once you reposition, bring it in center, and then try to negotiate. Here, the negotiation is slightly difficult, and your tip of the hysteroscope is just touching the anterior wall. So withdraw your hysteroscope, see the depression, and then again go forward. So in difficult cases, don't push your hysteroscope, otherwise you will be entering into the false passage. Try to locate the os. Try to locate the os by looking at the black and bring it in center. Again move forward and you will be in the cavity. Now, once you are in the cavity, again focus on the area first on the fundus, then right side, left side, and if you see any pathology, you can notice. For to look at the posterior wall, rotate it by 90 degree. Rotate your hysteroscope by 90 degree, keeping the camera fixed. So you have to fix your camera in the same position and rotate the hysteroscope. And that is how a good panoramic view is seen here. And again, when you are withdrawing, withdraw very slowly. So to see all adhesions and minor pathologies when you are withdrawing. Okay. So this is another difficult cavity to negotiate. Now here again you can see the distension of vagina is very important to locate the os. Here it is difficult. In this case, you can't see, the vagina is also not distending properly and the cervical os is not visible. You have to search. In some of the cases, the cervical os is just lying somewhere in the posterior fornices. So you have to withdraw your hysteroscope to locate the external os. And once you are able to, this is the posterior fornices, the os is somewhere anterior. So you have to see the os. Sometimes it is difficult, but most of the time you can find. Yes, see, you see it is here. And then once you see the os, you can enter and see the crypts of liver cone. Again, this is a patient which is secondary infertility, and here it is a very pinpoint os. You can see here the pinpoint os. So even a small hysteroscope may not be able to be negotiated. Now here, locating the external or internal os may be difficult in some of the cases, and once you find it, it is very small. So what you do, you can do either a dilatation of the os and with your grasping forceps. So that is one. Or you can make a cut at 3 or 6 o'clock position. Now here you can see this is a adhesion at the internal os, and you may think that this is the cavity, but it is not. So again withdraw from here and enter into the right direction. So this side is the cavity, deviated to right side, and once you enter, you can see the cavity very beautifully. This is the left ostia and this is the right ostia, and this is the panoramic view of this patient. So here you can see that their chances of getting into the wrong plane are much in these type of cases. Okay, so it is very important to know the technique of negotiating different types of cavity. If you are having a difficulty, you can use vasopressin solution 5 IU with lignocaine, and you can use it under ultrasound guidance or laparoscopic guidance. Blunt and sharp dissection may help you in those cases where you are having moderate stenosis. Either use grasper and open gently in the stenosis part of the os to widen the os, and then you can enter, or you can cut the ring under vision at 3 or 6 o'clock position. So these are some important tips. If you follow these tips, you will have a very smooth hysteroscopic negotiation. So, my dear friends, hysteroscopy is an important tool to diagnose and manage infertile couples. One has to know the technique of negotiating the cavity. In difficult cases, you have to take help of ultrasonography or laparoscopy to guide, because there are not many markers inside the cavity. You are having only 3 markers. One is the internal os, 2 ostia, and many other cases markers are missing. Like you are having only 1 marker, ostias are not visible. So prepare yourself, learn the technique, and enjoy doing hysteroscopy. Thank you very much for your patient hearing.
Thank you so much, respected Kuldeep Jain sir, for your kind efforts. We people could not differentiate between it was live lecture or a recorded session. So, Shelvala ma'am, please, would you like to say something regarding the lecture of Kuldeep Jain sir and Dr. Rana? Please say something. And please unmute yourself.
Hello, Dr. Kuldeep. It's nice to see you after a long time. Do you remember these days of Rewa? No. But you are not here, so I cannot talk to you directly. But your session was very good, as brilliant as you were in your yesterday days. And I hope that you will come to Rewa and we will definitely talk on some subjects. Nice presentation, Dr. Kuldeep. I wish all the success. Thank you. Hello.
Respected Prachi ma'am, would you like to say something regarding session?
It was a very nice talk regarding the hysteroscopic with steno, cervix, and all difficulties we face during the hysteroscopic. Even simple DNC, sometimes we have very much difficulty to dilate the cervix and all. So very nice talk regarding this. And we met the Kuldeep Jain sir just before few months, and it was a very nice experience at that time. So in future we can meet again with him and maybe more lectures about hysteroscopy and other infertility subjects. Thank you.
Yes, so, respected Padma ma'am, please invite the chairpersons of next session and speakers. Padma ma'am. Padma ma'am, please invite chairpersons of next session.
Now we are moving for our next session, and chairperson for the next session are Dr. Mahan Singh sir. Dr. Mahan Singh sir is MBBS DGO from SS Medical College Rewa in 1983, and he is a life member of IH and life member of IFUMB, trained in laparoscopy and hysteroscopy. He is a recipient of Pradhan Mantri Surakshit Matratva Achiever Award, and he has a special interest in infertility and high-risk pregnancy. Welcome, sir. Our next chairperson is Dr. Sarvesh Saxena, sir. He is MBBS from SSMC Rewa in the year 1988, MD in Obstetrics and Gynaecology in 1992 from the Shamsha Medical College, Rewa, and he did his senior residency from Mumbai, and he is a senior consultant and IVF specialist. He is trained for IVF from Boston, IVF Center, Boston, USA in 2010. Welcome, sir. Our next person is Dr. Sonal Agrawal. She is MBBS in Mathematics and she is Associate Professor in Sham Shah Medical College, Rewa. And she has got a special interest in high-risk pregnancy and infertility. Welcome, Dr. Sonal. The other chairperson is Dr. Nisha Agrawal, madam. Madam is MBBS from SMS Medical College, Jaipur, and she did her DGO from SS Medical College, Rewa in 1980. And she is the owner and director of Agrawal Nursing Home at Rewa and working as private practitioner. She is a senior consultant. Welcome, ma'am. Our first speaker for this session is Dr. Mansi Jain. And Mansi Jain, I welcome madam for your talk. And she is MS, Obs and Gynae, Diploma in Clinical ART. And she has got fellowship in reproductive medicine and surgery from Singapore. She is consultant in reproductive medicine, gynae endoscopy surgeon at KG IVF and Laparoscopy Center, Delhi, Indrapuram and Faridabad. She is a co-convener SIG endoscopy 2022 to 2024. She has got fellowship in reproductive medicine from Thomson Fertility Center, Singapore, fellowship in minimally invasive surgery from Max Hospital, Saket, presented papers in national and international conferences, chapters and books, delivered lecture and video presentation as national faculty, adapted in advanced Obs and Gynae and ultrasound, keen academician and research with special interest in reproductive medicine, National Coordinator Ultrasound IFS 2019 to 2021, Organizing Secretary Pre-Congress Workshop AOGD 2019. She got second prize presentation for paper presentation in ISAR 2016. Welcome, Dr. Mansi, for your talk.
Excuse me, Padma ma'am, sorry to interrupt you. Dr. Mansi Jain won't be able to deliver her lecture right now. So we will record. We will
recorded lecture is available.
Present. So
Okay.
our next speaker, Fareen Bharadwaj, Dr. Fareen Bharadwaj. Please invite us, Dr. Fareen Bharadwaj.
Welcome, Dr. Fareen Bharadwaj, for your talk on hysteroscopic polypectomy. Dr. Fareen Bharadwaj is Associate Professor of Gynae Endoscopy Department at MGMCH, Jaipur. He is a Secretary of Association of Gynae Endoscopic Surgeon, Rajasthan. Academic experience, he is running fellowship training program in gynecological endoscopy, lecture and clinics for PG students at Bombay Hospital. He has got many achievements and publication, original research article, role of hysteroscopy in evaluation of normal uterine bleeding, International Journal of Medical Sciences and Innovative Research, original research article in effect of letrozole in primary and secondary infertile patient in Journal of Medicine, Medical Science and Clinical Research. Welcome, Dr. Fareen, for your talk.
Thank you so much, Padma ma'am, for a kind introduction. And first of all, I would like to give thanks to the IFS Madhya Pradesh chapter, SIG Endoscopic Society and Rewa OBGY Society for inviting me and giving me opportunity to interact with all of you. I'm very thankful to Dr. Priya Bhape ma'am and Punita Bharadwaj ma'am and Kunjan Goswami ma'am for giving me this topic of endometrial polyp. So I'll start my presentation. Am I audible? Yeah, thank you ma'am. So just
You are muted, sir.
No, I'm not muted, ma'am. I'm not able to see this.
Okay.
And now it's visible. So fine. There's a few line about. Is the screen is visible?
No, no, sir.
Yeah, but is
Mhm.
You can
is, again, start with the distension of the vagina. That is very, very important. This is called vaginoscopy. Vaginoscopy.
Alligator or forceps or a grasper, grab the polyp, push inside the cavity, detach them, stop the inflow, and take them out. You can see we'll be removing one by one all the polyp in the same way. Detaching them with the help of grasper, pushing inside the cavity. If you have a space, suppose you are dealing with fundal fibroid, you cannot push them, you can just rotate them. As far as possible, we should not use electrosurgical devices in the endometrial cavity. If we can do with a cold mechanical instrument, it will be a friendly affair for the endometrium. So all the polyps were removed. 3, and this is the 4th polyp. And if you want, you can do a gentle suction. The curettage in the endometrial cavity should be avoided as far as possible. I hope the video quality and the speed is good. If I take my because of this online communication, sometimes we may not be able to appreciate the small details in the video. If it is so, you can ask me in between. Here I'm showing you the video of a polypectomy as well as a pedunculated fibroid polyp as well. I'm not discussing the myomectomy part, but I'm just doing it. Here, a big cervical polyp lying outside the cervical canal. So we are going with the help of vaginoscopic method. We saw a small endometrial polyp lying in the left lateral wall near to the ostia, and a pedunculated myoma arising from the anterior wall. Since there was a very less space, so we have gone with the 5 mm hysteroscope, the hysteroscopic sheath, and I'm using a 5 French bipolar electrosurgical unit, Bugbee, or you can say, or bipolar needle. With the help of this instrument, I'm cutting the polyp partly as close as possible to its base, and then with the help of the same instrument, I'll be cutting the base of this myomatous polyp. What other instrument we can use is Collins knife with a smaller size diameter resectoscopes are available. But I prefer in this case to cut it with by Bugbee, both the polyp as well as the myoma polyp. It was a thick pedicle, so I was using coagulating current as well in a small burst, and after coagulating the pedicle, we can see the specimen. So this was pretty big and a thick pedicle lying deep inside the endometrial cavity, and this is the post procedure picture. The cavity is looking decent. Now, it's another important video. This patient have become pregnant after doing Asherman surgery and diagnosed to have a missed abortion. So we don't want to use a suction evacuation or curettage in this case. So we go ahead with a hysteroscopic removal of this missed pregnancy, the same way as we are doing in style polyp. The procedure is exactly the same. You can introduce your hysteroscope, identify the location of the pregnancy. That also you can do it perioperatively with the help of ultrasound, and gradually you can cut. And as a fertility specialist, now we recommend this type of procedure in a delicate endometrium, so that you will cause less damage to the rest of the part of the endometrium. After detaching it, you can grab it with a grasper, and the products of conception is taken out easily. You can see in this, and the same was confirmed histopathology. So in endometrial cavity, which you have created by giving multiple efforts of hysteroscopic adhesiolysis, and the uterus is shown a pregnancy, you want to avoid curettage and damage to the endometrium, and hysteroscopic DNA is the answer.
You are not audible, Dr. Bharadwaj.
Sir, maybe because of some network issue.
Oh, I think there is some network issue. Fine. Okay. Is it visible now?
Yes. Yes.
Right.
Yes, you are visible and audible.
Fine. So may I know at what stage I was lost in the lecture?
Immediately after DNE.
Immediately after DNA. Fine. So this was a case of a postmenopausal bleeding, and let me see if I can. Yeah. Is it visible now, the video? Fine.
No, video is not visible.
Video is not visible. Again, I need to reshare it.
Yes.
Please give me a minute, otherwise I think I have not crossed my time limit. Is it so? The chairperson?
Okay, you can go.
I can go ahead. Thank you. I'll just take a minute. So the hysteroscopic DNA is one of the important aspect as an IVF specialist, I should say. If we are dealing with missed abortion, a very small abortion, because medical termination sometimes can give you chances of our retained product in missed abortions. See, medical termination of pregnancy works well in a healthy pregnancy. So, it's able to do hysteroscopic DNA. In fact, in abroad, people are doing medical termination, MTP, surgical MTP, with the help of hysteroscopic. They are identifying the pregnancy from which wall it is originating, and then they are detaching it and doing a selective suction or curettage in that particular wall, which will reduce the chances of developing intrauterine adhesions. Okay, is it visible now?
अभी तो देखना पड़ेगा.
Is it okay, ma'am?
Yes. Now video is visible.
Fine. Am I audible?
Yes.
So I have two more videos. One is this. This is a case of a postmenopausal bleeding, which the ultrasound shows a mass in the cavity, which is completely filling the cavity, not able to appreciate from which side it is originating. In such cases, entering inside the canal and then complete evaluation, thorough evaluation of cavity is extremely important. So the two basic landmarks are both the osteas. After confirming that you are lying between the two osteas, then you should locate the pathology, see the origin of the pathology, from which wall it is originating, anterior wall, right wall, left wall. I'm talking in the cases where we are dealing with the big pathologies like big fibroids, big mass, placental polyp, and then selectively, targeting that wall, shaving the pathology from that wall. In such cases, if you go underneath that pathology, the jet of the water will lift the pathology up, and you can do the procedure. And this is my last video. So this was a case of a endometrial hyperplasia, ultrasound report, and when we entered inside the cavity, you can see an unhealthy endometrium. And then when you go deep inside, nicely you can see some area of necrosis, some unhealthy endometrium, and then you go close to the endometrial lining, and then you try to see the abnormal vascularization, neovascularization, and which will, give you idea. In such cases, the hysteroscopy has a very good role. You can take the biopsy from these particular areas selectively, and visualizing the cavity in a low pressure is extremely important. Always remember, when we are using a very high pressure, sometimes you may miss certain pathologies. So after completely evaluating the cavity, I can see a posterior lateral wall sessile polyp with areas of neovascularization and abnormal vascularity. And then in sessile polyp, it's always better to start, slightly away from the margin and gradually lift up the pathology with the help of scissor. And rest of the procedure is same. You can go as close as possible to the basal endometrium. Remove the mass. A small tag should be left, and then with the help of grasper, you can grab it, stop the inflow, and take out the tissue for the histopathological examination. This was a case of an adenocarcinoma of endometrial cavity. So, thank you so much for giving me this opportunity to interact with you. I'll be happy to answer if there is any question and queries.
Dr. Pareen, I have one question. Okay.
Please.
Can we do DNA in a case of polypectomy for reduce financial burden of patient in spite of
Ma'am,
to remove polyp, small polyp?
If it is a symptomatic polyp, ma'am, if it is a symptomatic polyp, then it's better to do hysteroscopic guided. It's advisable. Otherwise, the textbook, the literature says that 20 to 30% of the polyp which are less than 1 centimeter or 0.5 centimeter, you don't need a surgical procedure particularly. But if you're dealing with a infertility patient, and planning to do a embryo transfer, it's better to remove such polyp.
Okay.
And it's always better to put a hysteroscope inside. Financial burden is not our choice, ma'am. Let the patient decide about this. What we can do, we can offer them a standard procedure and let them choose whatever they want.
Okay. Thank you. Thank you so much.
Welcome.
Thank you, Fanin sir, for such an informative talk.
Thank you.
Now I would like Sarvesh sir to summarize the talk. I would request Dr. Sarvesh Saxena sir to summarize the talk.
Padma, there are other speakers also, no?
Yes, sir. To summarize the talk of the sir.
Yeah, this talk only.
Yeah, this one.
Okay, as Dr. Bharadwaj has spoken about the adenocarcinoma and carcinoma, we do have these contact histoscopes also. So we can go for the contact histoscopy, and then we can very well decide what will be the next line of treatment after we do the histoscopic resection of the carcinoma, as you have said in your last video. And then later on we can plan the further management.
100%.
And I will just like to ask a simple question. What is the your suggestion regarding this estridiol valerate or estridiol hemihydrate after resecting the polyps in cases of infertility? If there are multiple polyps and we have to go for an IVF, do you recommend these things or not?
Sir, as we go into the basics of pathology of endometrial polyp, they are hyperestrogenic condition, which are reflecting in the form of endometrial hyperplasia, endometrial polyp, and again there are certain genetic composition and other hormonal and receptor level problems. So for estrogen, hyperestrogenic state, progesterone is a solution and not the estrogen. See, the estrogen is a solution for thin endometrium. So I'm very selectively using a scissor to remove this polyps even in multiple wall, and there are very less chances of developing adhesions. Unless until you are breaching the basal endometrium at a significant areas, then there are chances of developing adhesion. I think you are talking about using estrogen to prevent the adhesion formation.
Adhesions, yes,
The
definitely.
chances are very less because these conditions are hyperestrogenic station.
Yeah, because you had already said in your video that you are not using any power or any current.
Yes,
only,
sir, as far as
only
possible.
mechanical scissors you are using it.
Because, sir, if you use, even if you have to use a resectoscope, see, the current delivery is not appropriate when you're using it on an endometrium. You might have to use a higher frequency, higher voltage pure cutting current to cut this endometrium, which can cause more damage. It's better to use cold scissor. For the retrieval purpose, we want to cut the polyp into a small pieces. That can be easily done with the help of mechanical instrument. Nowadays morcellators are available, or otherwise, sir, we are a conventional gynecologists. You can cut the polyp from the base. You can use a ovum forceps to grab after dilatation, you grab the tissue and take it out easily, rather than using electrosurgical in fertile patient.
Okay, thank you.
Thank you so much.
Padma, kindly continue.
Yes, sir. So, thank you, Dr. Farin, for your talk. Now we are moving to our next talk, that is by Dr. Punita Bharadwaj, madam. Welcome, ma'am. Punita Bharadwaj, madam, is going to speak on hysteroscopic management of submucosal fibroid. Madam is trained and graduation. She did her graduation from Lady Hardinge Medical College, New Delhi, and post-graduation from Kasturba Hospital, New Delhi. She did her endoscopy training from UK, USA, Germany, and robotic from France, Strasbourg, and doing exclusive gynecological endoscopy for past 22 years. Welcome, ma'am, for your talk.
Thank you very much. Thank you, Rewa Society. Always look forward to the local society in participating in such webinars. Let's straight away go to the topic. My topic that Kunjan decided for me was submucous fibroids. So can I have the video, please? Can you hear me?
Yes, ma'am.
Yeah, so I take you through a case series that we managed hysteroscopically of submucous fibroids. This was a elderly lady, she was about 40, came for infertility, and look at the fibroid that she had. Low, very low and broad based. I'm using a monopolar resectoscope. Yes, you should be using bipolar and monopolar, whichever you are comfortable with. The idea is to be aware of the problems associated with both. You see that? What I did was I took off the first layer and I could roll the fibroid on this thing to make it more submucous so that I can deal with it. I'm using a monopolar resectoscope with glycine as distension media, and I'm moving the loop of the resectoscopes towards me. Yeah. Depending on the size, the pressure is decided on the loop. It is a 26 French loop, and the 7 to 8 millimeter size hysteroscope suffices. And what I did was I started in the center, but I'm proceeding from the sides to prevent that sinking in of the submucous fibroids. That's the cavity, and you appreciate the position of the fibroid there. Idea is to reduce the injury to the endometrium as much as possible. This was another case. She was a young lady. She was about 28, came with the hemoglobin of 4 gram% with lots of bleeding during the periods. And all she needed was, I did an MRI mapping to differentiate the fibroids, different locations, positions, and most of them were submucous. What we can do in such cases is you can prepare her. One, you have to basically make her hemodynamically stable and look at the bunches of fibroids all over. I didn't want to intend you to get scared of such cases, but we went ahead and did it in single sitting, although there has be a debate about a single sitting in this. Because when you do opposite walls, they tend to stick together. But what I do is I use a Foley's tamponade. This is the intrauterine morcellator. I was trying it on this case, but the fibroids were so low down that the camera vision was obstructed when you have a lower down fibroids. This morcellator can be used for selected cases. Intrauterine zero submucous fibroids, G0 fibroids. It is very rapid and it doesn't damage the endometrium, So I think that's very good in those cases. So selective usage of this case. Moreover, there's nothing to control the bleeding, because in such cases, when you have such a fragile endometrium, bleeding endometrium, it tends to bleed. So you have to have an energy source to be able to control the bleeding. And the trick is the same: to minimize the endometrium damage surrounding the fibroid, just remove the strip over the fibroid and gradually go down, slicing the fibroids bit by bit. You have various methodologies in such cases, like the Litta's technique and the Lasmar's technique, where you give a semilunar incision with a Colin's knife, and then you prevent the sinking in of the fibroid with that attempt. And the Litta's technique is when you give an L-shaped incision at the junction of where the endometrium touches the fibroid. So in that case, again, the damage done to the endometrium is less. Two, you reach the fibroid without injuring too much of the endometrium, which is so important for infertility patients. This patient also would go ahead for a motherhood, and we don't want synechia formation. Of course, I use a physical tamponade. You can also use hyaluronic acid gel and ceprafilm and all that, but I've always used Foley's, 18 number Foley's for tamponade. With depending on the size of the cavity, the Foley's bulb is inflated. The type 0 of fibroids, you need to have the classification like the Lasmar's and the Wamstaker classification. One needs to know that before we can attempt hysteroscopic myomectomy. I will not go into the theory. I'm sure everybody is aware of that aspect. What I'm trying to tell you is that even this is extreme hysteroscopy, of course. The principle remains the same with each fibroid, one by one. And this, of course, should be done in a post-menstrual stage where your endometrium is not fluffy. And one can use intracervical vasopressors to reduce the endometrium from fragility and reduce the bleeding during the myomectomy and keep the vision intact. And as you get closer to the myometrium, the pressure on the resectoscope loop is reduced so that you are not inadvertently damaging the endometrium. Basically, you can make out the difference between the fibroid and the underlying rolled myometrium, which is more pink. Fibroid is more white. So the idea is to just remove the fibroid and remain within the capsule, so that the damage to the endometrium or the myometrium is minimum, and post-surgical synechia formation is reduced as much as possible. Of course, one has to understand that the energy that you're using with monopolar, somebody is doing an input-output balance continuously. It is not post-surgery that you do that. You do that continuously. One person has to be at the glycine or the saline in case you're using a bipolar resectoscope, whatever you're comfortable with. Of course, the safety margin is much more with a bipolar resectoscope, although overloads can happen even with bipolar and using normal saline as distension media. You see, this fibroid is so close to the ostia. One has to be very careful and gentle. What I'm doing is flipping my resectoscope over the fibroid to know the depth and to know the size of the fibroid, so that I just lift off the fibroid from the base and not damage the area around it or go too deep. You can appreciate the pink fibers of the myometrium, and gradually you just remove the all the flakes. A lot of people talk about 2 sittings. A lot of people talk about GnRH analogs prior to this thing to reduce the size. I agree to all that, but recurrence rate and repeat surgeries are required, because in GnRH analogs, the smaller fibroids disappear. And with their disappearance, when you don't see them, you all obviously don't deal with it in that sitting. So the patient will have to come back for a second sitting minus the GnRH, so that you can identify all the fibroids in there. When you have multiple, of course, like I said, MRI mapping is required. You see the numbers that were here. Overload is a big possibility in this. And that is why I stress on the input-output running balance. A lot of systems are there where these endoscopic chips can be taken into this one system, and input-output balance is dynamic. But in those cases, again, like the intrauterine morcellator, the energy source is not there to reduce the bleeding then and there in case the vascular sinuses open up. Vasopressin advantage is that also using vasopressin at the cervix is it reduces overload, it reduces bleeding, it improves the vision, and you are faster. Of course, such cases should not be attempted in the beginning of your career. You should start simple, like that is the principle in most cases. Start with simple, smaller cases, and then go ahead and do these cases as your experience builds up and you understand the nuances and your hands are adept at handling such cases. Now, this one was a case of a post-pregnancy uterus with a large submucous fibroid. She had an abortion, and after 8 weeks of post-abortal, we attempted this. You realize that the texture of the fibroid is more degenerate. It is less defined. It is less firm. And the layering that you see is that of a degenerate fibroid that happens post-pregnancy. Here, the loop is moving towards you. Always the loop should be moving towards you so that you can visualize the loop when it is coming towards you and you don't inadvertently have a perforation on your hand. The vision, of course, has to be good. You should be adept at the energy sources. You should know what's happening with the current. And the setting on the current, the cautery settings depends on the cautery that you're using. A lot of us use the local cauteries. The trick here is that the loop should slice through the tissue. If the loop is slicing through the tissue without the tissue sticking to the loop, that means the current that you're using is correct. And the results that you will get will be adequate. And like I said initially also, the pressure on the loop is the key. And of course, the time duration, the size, all that has to be taken into account to prevent overloads. So what are the complications we are looking at? Perforations, trauma, injury to the endometrium, and overloads. One has to be careful that when you have an overload of a 750 ml, one has to be careful and fast and finishing the surgery. If it is the deficit of the fluid is about 1000, one should quickly wind it up and finish it. And anything more than 1000, look at how big the submucous fibroid is. Anything more than 1000 or 1500, you should stop. Of course, the basic baseline of the patient is important. This case was a bleeding tissue. She was a young girl, 34-year-old, not responding to any hormones, long-term hormones. And look at the tissues. They are so soft and muggy. You realize you touch the endometrium and she's bleeding. You touch the endometrium and she's bleeding. The vision you realize the difference between the first submucous fibroid that I showed to this. A lot of bleeding is happening even when I'm slicing the fibroid, and the planes between the fibroid and the myometrium are visibly lost. You see the kind of vision that you're getting here is not as good as you were getting in the first two or the third case also. So bit by bit, with patients monitoring the input-output balance, you do the hysteroscopic myomectomy. Of course, your anesthetist, the table has to be horizontal always. There are no head lows in hysteroscopic myomectomy. And the anesthetist picks up the overload first. So the PiO2 of the patient collapses, the EtCO2 monitor, the oxygen saturation, all that is visible on the monitors in good centers. Of course, you're using a hystomat in these cases. So when you have an hystomat there, you understand what are the pressures, what is the volume like, and you monitor the running balance of the input-output fluid. That's very important. I think the video is over. Any questions? I'm open to it. Thank you very much for a patient attentive hearing. Thank you.
A very informative talk, ma'am. Actually, we are delighted to see your videos, and even I cannot imagine that removing such a big fibroid, submucous fibroid, by hysteroscopy. Now, I would like request Dr. Mahan Singh sir to summarize Punita ma'am's talk. Mahan Singh sir. Dr. Sonal Agrawal, if Mahan Singh sir is not there, you can summarize madam's talk. Dr. Sonal?
Yes, ma'am. Good evening, ma'am. A very, very informative talk about submucous fibroid and their hysteroscopic management. And I'm sure all our listeners must be very benefited from the same, ma'am. We have one question from our audience, that whether, ma'am, any kind of hormonal treatment should be given for cavity integrity after these kinds of procedures to prevent infertility in the same patients?
No, I do not give any hormones, like it was said by Dr. Farendra also, that fibroids are a hyperestrogenic state. Yeah. What I give is a barrier Foley's catheter in case of multiple fibroids. I put on the Foley's and put the entire thing into the vagina. I keep the catheter on for 48 hours to 72 hours, depending on the case. And that's how I avoid this thing. And I do a 3D ultrasound after 3 months. You know, when I expect a large deficit, you know, when I expect that the other opposite wall is also involved, then probably I would think about estrogen if I have not given a barrier tamponade or a barrier, Foley's barrier to prevent adhesions. So this is what I use, and I'm very happy with the results. The multiple fibroids that I showed, the second case, that I presented in the American Association of Gynae Laparoscopy also way back. And even they were surprised. In fact, that girl got married within a year of the surgery, and she was pregnant in 8 months' time, spontaneous pregnancy. So I have results to speak of, you know. So there was no adhesions. And in such cases, if you do a good job, it's very gratifying. Number one, you've solved her problem of menorrhagia. Number two, if you've not induced any infertility, she's good to go like any normal person. So I individualize. I don't say never, say, like I said, never say never. Hormones can be given depending on the cases. Like I said, if I'm using a Foley's and it's worked well, I wouldn't give a hormone in all cases.
Ma'am, one question. For how many days you put Foley's? For
48
how many hours or days? 48.
48 hours. Yeah.
Yes, ma'am. Ma'am, there is one question in chat box. Which fluid is better for operative hysteroscopy?
Which fluid?
Fluid, yeah.
See, if you're using a monopolar, I began my career using a monopolar. So my hand is set on a monopolar. And I use glycine as a media. And I'm careful about my balances. I'm careful about individual patients. And we do have a bipolar. which is a recent acquisition, and we use normal saline for that. है ना?
Yes, ma'am.
But one carry home message I want to deliver is that it doesn't mean that if you're using a bipolar, you will not get an overload. You have to be careful even with a bipolar. Any long surgery, any open sinuses, even the saline gets absorbed, and you do get overloads with salines, but they are less severe than a monopolar. Glycine has more dramatic effects than normal saline. So for beginners, you start with the small cases and gradually upgrade yourself to bigger cases.
And there's one more question in the chat box. For how long we should wait for pregnancy to occur? Like we have to.
See, it depends on the depth. What level of myomectomy you're doing. Is it a grade 0, grade 1, grade 2? That means what is the intramural component? You see? So you don't have to wait like you do in a lap myomectomy. You don't have to wait for 3-4 months. But in a hysteroscopic myomectomy, if you've done a good case selection, it is good to go if you use 1 month or 2 months. Once your cycle resumes, and the effect of antibiotic that you did for hysteroscopic myomectomy is gone, you are good to go. Of course, you need to individualize cases. And if you're doing a case which has reached a serosa, which is 5 millimeter away from the serosa, I think you have to wait longer.
Ma'am, have you seen any case of placenta accreta in such type of cases, like patient became pregnant and is there any increase in the risk of placenta accreta?
No. Like I said, reduce your damage, confine yourself to the fibroid only. Do not damage the myometrium. Don't go deep. If you go deeper, you will be indicated by bleeding. If you remain within the capsule, you're fine. She hardly bleeds. The scarring will be less. So if you follow the principles, there'll be no accreta. Okay. If you follow the principles, there will be no accreta. Follow the principles of preventing adhesions and you'll be fine. If you leave bleeding tissues, if you leave sinuses open, and I think hysteroscopy, myomectomy, once you massage the uterus, all that stays away. The uterus contracts beautifully. And if there is no bleeding, if you're not using your Foley's for tamponade just as a barrier, then I don't think there is any chance of it.
Can I add? Hello? Hello?
Yes,
Hello?
sir.
Yeah.
Hello?
Yes, sir.
Yes, Dr. Farid. Yes.
Ma'am, all the videos were, giving me goosebumps. It was wonderful. I can, being a hysteroscopic surgeon, I can understand, how difficult these cases are. And you did it wonderfully. And I have witnessed many of your surgeries, live. You're a very calm surgeon. And to attempt such type of cases for the audience, you need to be very calm and comfortable when you're operating. And ma'am, one question, for the second case, how, because that was a very big cavity, I can see.
Yeah, it was a very big cavity and she responded beautifully. I was surprised at the results. I did call her for a follow-up after a month and we did do a 3D ultrasound. There was a dramatic improvement in her menorrhagia and her cavity gradually resolved. Because most of the fibroids were submucous.
Yes, most of them, yes.
Most of them were submucous and I hardly faced anything which was going beyond that was a very, interesting case in the sense that all the fibroids were confined to the mucosa and that is why she was bleeding like a tap. Our 4-gram hemoglobin, building her up was difficult because from one cycle to the next, you would bleed again. And I didn't want to give her a GnRH because the moment you give a GnRH, some will disappear. You observed the tiny ones, which I just lifted off with this thing. So those would have gone and she would have come back for a second sitting again. I didn't want to do too much of handling.
You have stretched the boundaries of, hysteroscopic myomectomy.
Absolutely, yeah. This I presented in AAGL also, and they were very appreciative of this thing. And I think I should be publishing it, but how we are, we just keep doing cases. Thank you very much.
Thank you so much, ma'am, for a wonderful insight.
Thank you. Thanks a lot.
Thank you so much, ma'am. Thank you.
Thank you.
Thank you, ma'am, for wonderful talk.
Thank
Now
you.
we are moving to our next speaker. Now Dr. Mansi Jain has joined, and I invite her for her next talk on hysteroscopic adhesiolysis. Dr. Mansi, as I already mentioned, she did her MS and diploma in clinical ART. She is the organizing secretary pre-congress workshop AOGD 2019, and she got second prize paper presentation SR 2016. Welcome, Dr. Mansi Jain, for your talk.
A very good evening to all. I'm Dr. Mansi Jain, and on behalf of SIG Endoscopy, I welcome you all today for this webinar on mastering skills of hysteroscopy. We all know that implantation has always been the rate limiting step for any ART procedure. It's all about selecting the right seed for the right soil. And today I will be speaking on the soil, that is the endometrium, and one of the most common entities that we encounter in our daily practice, that is intrauterine adhesions. So intrauterine adhesions can be because of Asherman syndrome or acute or chronic endometritis, but both of them result in implantation defects. In my lecture today, I will be discussing the role of hysteroscopy in battling Asherman syndrome. Now, a patient of intrauterine adhesions or synechiae may present as oligomenorrhea or, in worst cases, even amenorrhea. Patient may also present as having infertility or may be asymptomatic, as in most cases, because of which it goes undiagnosed. Now, it is important to make a proper diagnosis before moving on to the treatment, and this can be done with the help of various modalities which can be used alone or in combination with each other, like HSG, SIS, transvaginal scan, which can be 2D or 3D, with or without power Doppler. However, hysteroscopy remains to be the gold standard when it comes to the diagnosis of intrauterine adhesions. It is important to classify the disease, and this is very important to be able to make the right diagnosis in grading of the disease, and most importantly, managing the disease, prognosticating the disease, and counseling of the patients. However, over the years, various classification systems have been proposed, but without any common consensus or guidelines. At present, what we use is the European Society of Gynae Endoscopy classification, which was given way back in 1995. And according to this, intrauterine classification, intrauterine adhesions are divided into 5 grades. And we will be discussing one by one each one of them. Now, my first clip here shows a video of Asherman syndrome grade 2, which is relatively very easy to operate on. Now, I say this because, as you can see here, we have a very thin, flimsy band of adhesion on the on the right lateral wall, and a single band of dense adhesion on the fundus. Now, the flimsy bands of adhesion can also be dealt with by blunt adhesiolyzers with the sheath alone. But in this case, you can see I'm using a hysteroscopic scissors, which is the other way of doing it, and we are doing sharp dissection with the help of hysteroscopic scissors. Like I said, it's an easy procedure. However, a couple of things must be kept in mind to avoid any complications. Like for example, at all times, the tip of the scissors, the instrument should be under vision. It should not be a blind procedure. The direction of the scissors should be perpendicular to the plane of dissection. Also, it is important to keep the fluid balance in place, and which is common for all hysteroscopic procedures. So you can see we have done the hysteroscopic adhesiolysis in this case, and I will just move on to the end of the surgery, and this is the final picture that we have achieved. Moving on to the second clip, which I think is more interesting, because here you can see we have a cavity which is full of adhesions. You can see that there are multiple thin bands of adhesion running between the anterior and the posterior uterine wall, and it almost gives the impression that the cavity is divided into multiple chambers. The principles of adhesiolysis remain the same, and you will notice here that a good distension is also the key to a successful and comfortable surgery, because you will notice when you are doing sharp dissection and you're cutting through the fibers, if you have a good distension, the cavity gradually opens up. The fibrous bands are seen to be separating and the cavity gradually opens up. Now we've reached a point which seems to be the ostia. You can see here, this seems to be the ostia and the fundus, but if you closely notice, this is only a band of adhesion. You can see the fibrous band and no normal endometrial tissue here. So again, we're doing adhesiolysis here, and as we are opening up the these fibers, now we can finally see the rest of the cavity. So this is the upper end of the cavity. You can see the fundus here, and you can see the fundus has dense adhesions. This is one of the ostia, and you can see the fundus has dense band of adhesions. So we have to use sharp dissection here, again with the help of hysteroscopic scissors. So when dealing with this fundus, especially, one must give very controlled small bites, starting from the center of the fundus and gradually moving towards one side. Large nicks here should be avoided, otherwise you'll straight away reach the myometrium, which you don't want. The important question here is the end point of the surgery. So, well, mostly what is taken as the end point is that when you get a panoramic view, that is from the internal os, both the ostia should be visible and should be in line with each other, forming the perfect triangular uterine cavity. And this is considered to be the end point. However, this may always not be the case, because in cases where you have a distorted cavity, or in cases where the cavity is rotated along its axis, it may always not be possible to view both the ostia in a perfect line. So in those cases, you look for the crisscross arrangement of the myometrial fibers. So while dissecting, when you reach the crisscross arrangement of myometrial fibers, that is your cue, and that is where you should stop. So we have reached the end of our dissection, and you can see this is the final cavity after the surgery. Okay, so moving on to my third clip. This is a video demonstration of lateral metroplasty. You can see this is a typical grade 3 endometritis with dense fibrous adhesions on both the lateral walls and a thick band of adhesion over the fundus. So we proceed with the fundus first, and like I said earlier, small controlled nicks to be given on the fundus, starting from the center of the fundus and gradually moving towards one side, with both the ostia as the landmark here. And once we have finished with the fundus, now we can move to the lateral wall. So the trick here, the problem here mostly is because of the placement, the laterality of the wall, and you can notice that the fibrous bands here are quite thick. So what one can do is you can fix one end of your the blade of your scissors and move the other free end for dissection and gradually move forward. Also, lateral metroplasty is one of the selective indications for the use of energy source in a fertility preservation surgery. So because you can see the bands here are quite thick, and at times it may be difficult for you to do the metroplasty. So using an energy source, like in this case, I'm using a unipolar hook, may seem as a good option. Only thing you need to remember is that the movement has to be controlled it has to be in one go, and should always be towards the surgeon and not the other way around. Otherwise, the risk of perforation and endometrial damage are more. So this is the final picture after correction. Okay, and finally moving on to the last case, that is a typical case of grade 4 Asherman. So we move beyond the internal loss and we can see the cavity. You can see most of the cavity is obliterated with minimal normal looking endometrial tissue. And this is the case in most of the grade 4 or the severe Asherman. Now the problem here is that you can see both the osteas are completely obliterated and not visible because of the dense adhesions. So it may be very difficult for you to decide where to start your dissection from. Now the key here is to be very patient and look for a reference point. So you would have noticed in the beginning there was a small hole that will serve as your reference point. So you start your dissection keeping that point in the center, and then you gradually make small nicks and move towards one direction. But at all times, that point remains to be your reference point. So now you will notice that was the right cornu, and the area next to that we have freed is the fundus, and we had to do lateral metroplasty as well in this case. And this gives you a better picture now. Also, in these cases, it may be very wise to take the help of a intraoperative ultrasound guidance to avoid the risk of perforation. The aim in these cases should be to restore the endometrial cavity to as normal as it can be, and do maximum correction to give the patient the benefit of maximum chances for conception. So that was the final look of the cavity. Now the management of grade 4 endometritis or Asherman does not stop at surgery alone. There has to be a vigorous and meticulous post-op follow-up and for prevention of intrauterine redevelopment of intrauterine synechiae. This thing has always been in debate because we have so many modalities like progesterone releasing or copper or T-shaped IUDs, or insertion of Foley's catheter as an option, or insertion of hyaluronic acid, or use of estrogen with or without progesterone. So we have a couple of options, but which one is the best has always been debatable. So I'm going to share with you the AAGL practice guidelines for post-op management of intrauterine synechiae, and this was given in 2013. So according to this, we have grade C evidence that neither progesterone releasing nor copper nor T-shaped IUDs should be used after the surgical division of intrauterine adhesions. We also have grade C evidence that there is limited data supporting a benefit for using a Foley's catheter on an IUD. Then there is grade A evidence that barriers such as hyaluronic acid and autocross-linked hyaluronic acid gel seem to reduce the risk of adhesion recurrence and may be of benefit. Also, there is grade B evidence for the use of estrogen with or without progesterone, and they may help in reducing the recurrence of intrauterine adhesions. We as a routine practice at KJ IVF use estradiol valerate 2 mg TDS for a period of 3 to 6 weeks minimum, which may be extended to up to 8 weeks in cases of severe Asherman. And this is what we've been using. This is usually backed up by assessment by transvaginal scan with power Doppler to plan the further management. Also, transdermal estrogen in the form of estrogel can also be used. Also, this is one scenario where the role of second look hysteroscopy cannot be overlooked. So, for this, the patient has to be counseled before the first surgery that there may be a need of a secondary look surgery to attain the desired result. Now, this is our data from KGIVF. We studied over 500 patients over the span of 6 years, and we noted that there was abnormality detected in almost 55%. Out of this, all were corrected, and we were able to achieve a conception rate of 35%. The prognosis of the surgery depends on the severity and grading of the disease. It also depends on the tissue characteristics, the volume of the cavity involved, the quality of adhesions, whether thick or thin, and the visibility of ostia. So, in the end, I would just like to conclude by saying that proper selection, good skill, and superior instrumentation is the key to a great outcome. Patient's expectation should always be kept in mind while counseling the patient. However, a very flowery picture, especially in the more severe grades, should not be conveyed to the patient. A definite plan of action must exist for risk management. Fluid monitoring, like I said, is a vital part. And in fact, one person should be designated in the OT just to keep a track of the fluid. Coagulating current in fertility preservation surgery should be avoided as it is more adhesiogenic. And finally, the key to avoid complications is proper training and proper patient selection. Thank you.
Very nice presentation, Dr. Mansi. Now we move on to our next speaker, Dr. Dhaval Bakshi, for his talk on hysteroscopic septum resection. Dr. Dhaval is SRA certified reproductive endoscopic surgeon. He is a gynecological endoscopic surgeon and fertility specialist of Disha Infertility and Motherhood Hospital in Indore. He is trained at Rewa Hospital in Ahmedabad with Dr. Deepak Limbachia and at ISSA Nagar, Italy with Dr. Marcello Caroni for advanced endometriosis surgery. He is a gold medalist MCH and he is a joint treasurer MP Chapter of IAH, managing committee member MP ISAR, winner of the Best Paper Awards at MP ISAR Conference 2013, Yuva Foxy West Zone Conference 2015, ISAR 2019, champion of ISAR Award 2020, and he is a winner of Dr. Praveen Patel Memorial Award for Best Video Presentation at ISAR 2016. He is a winner of Dr. Shivli Rudra Sinha Award at AICOG 2022. Welcome, Dr. Dhaval, for your talk. Dr. Dhaval?
Ma'am, he is not picking up my phone.
Okay.
I think he is in some emergency. So can we move on next session?
Yeah, we can.
So so thanks to all chairpersons. Thank you, Dr. Sonal. Thank you, Nisha ma'am. Thank you, Sarvesh sir. Thank you, Mahen sir. Thanks to all, sir. Now, our next session is about complications in hysteroscopic surgeries. So, I would like to invite all chairpersons of this session first. So, our first chairperson for this session is Dr. Sagar sir. Good evening, sir. Dr. Makhan, please share the slide of Sagar sir. Mr. Makhan. Sagar sir is co-owner, consultant, obstetrician, gynecologist in Sagar Nursing Home, and his qualifications are laparoscopic training in gynecology from Bellevue Hospital, Calcutta, advanced USC training from Fetal Medicine Center, Apollo Hospital, Delhi. His education MBBS is from Calcutta Medical College and MD degree from Rewa Medical College. Welcome, Sagar sir. Our next chairperson is Dr. Priyanka Tripathi, ma'am.
Hello, Dr. Gunjan.
Welcome, Priyanka, ma'am. Priyanka, ma'am is a gold medalist in her MBBS and have many project work on. One is on 75-gram glucose, single red glucose challenge test. Received SC Saxena Award at MPOX 2017 Indore for paper presentation on PPIUCD. And she is currently Nodal Officer Janani Suraksha Yojana in Medical College. Welcome, Priyanka ma'am. And our next chairperson is Beena Mishra ma'am. Welcome, Beena ma'am. Beena ma'am is Director of Mishra Nursing Home Seedhi and Pratham IVF Center in Seedhi and in Rewa. Welcome, Beena ma'am.
Actually, there is
Now
some network.
I would like to invite our speaker, Dr. Padma Shukla ma'am, for her talk on complications of hysteroscopic surgeries.
My screen. Good evening, everyone. My topic is complications in hysteroscopy. So, although all of the speaker before me, they have already cleared so many things and they have covered most of the topic. Even with good car with its safety features and with good road, the driver still has to drive carefully to complete the journey safely. So point to discuss is incidence of hysteroscopy complication, perioperative complications, post-operative complication of hysteroscopy and its management. Incidence of hysteroscopy complication, it is 2.7 to 3.8% of all hysteroscopies, and a multi-center study in the Netherlands, it explained that with the diagnostic hysteroscopy, the complications are less, that is 0.13%, and with operative hysteroscopy, it is more, 0.96%. Highest rate of complications are seen with the hysteroscopic adhesiolysis. Complications are reduced nowadays significantly because of improved equipments, better understanding of risk factors, and proper training and better experience of operating surgeons. Operative hysteroscopy, it is not for the novice, but should be an extension of basic skill learned at diagnostic hysteroscopy. It is recommended that unless you have done 500 diagnostic hysteroscopy, you should not venture operative hysteroscopy, or at least you should have well versed with the technique. Perioperative complications of hysteroscopy are, it can be with the patient positioning, vasovagal attack, anesthesia complications, access to endometrial cavity, cervical trauma, false passage, uterine perforation, intraoperative bleeding, thermal injury, and fluid overload.
Okay.
Post-operative complications, it can be early or late. Early complications like infection and post-operative bleeding. Late sequelae is persistent complaint of the patient, intrauterine adhesions, hematometra, uterine rupture during pregnancy. Incorrect patient positioning can lead to nerve injuries, back injuries, and damage to the soft tissue, and can lead to compartment syndrome. And lastly, deep venous thrombosis. Patient position. As we all know that the modified lithotomy position is the ideal, in which we have to do the moderate hip flexion with the limited abduction and external rotation. Femoral neuropathy can be seen when there is a defect in the patient positioning, like excessive hip flexion, abduction, and external hip rotation. Extreme angulation of the femoral nerve lead to compression of the femoral nerve. Although this injury of femoral nerve is temporary and it needs intensive physical therapy to resolve. Sciatic nerve injury can occur at the sciatic notch, and common peroneal injury at the neck of the fibula. That can lead to foot drop or lower lateral paresthesia. Brachial plexus injury can occur from incorrectly placed shoulders, leaving the patient's arm abducted on an arm board. A non-slip mattress is preferable to restraint that compress the patient's shoulder. Injury can result in 15 minutes from a faulty position. Back injuries, it can occur as the anesthetized patient is defenseless against traction. Injury to the lumbar spine. Legs should always be lifted simultaneously and kept together until they are at the appropriate height, when they should be abducted gently and placed in supports. Legs should never be over abducted. It can lead to damage to the sacroiliac joint. Compartment syndrome in lower limb, it can occur due to pressure on the muscle of an osteofacial compartment. With the pressure, there will be ischemia, then reperfusion. That lead to sequelae of rhabdomyolysis and permanent disability. Event facilitating it are leg holders, pneumatic compression stockings, and any direct pressure on the lower limb. Risk reduction. Proper lithotomy position is required. Avoid pressure on the prone areas and avoid leaning on the thigh of the patient. And early identification and management. Vasovagal attack. Proper evaluation to prevent vasovagal attack. Proper evaluation to rule out pre-existing heart disease. Installation of LA local application, local xylocaine application in cervical canal may reduce incidence. Although routine administration of intracervical or paracervical LA is not indicated. Anesthesia-related complications. It could be local anesthesia-related like allergic reactions, cardiovascular complications. And anesthetist should be aware and he should avoid fluid overload and electrolyte disturbance. Injury to genital tract. I think most of the part is covered by previous speakers, like cervical laceration, false passage, perforation, and bleeding. I don't have video because I didn't come across the such complications. So cervical injury, it can occur due to excessive traction on cervix by tenaculum. When cervix is forcefully dilated, then also cervical injury can occur. Predisposing factors like nulliparity, menopause, and cervical hypoplasia. Dilatation itself can also cause bleeding from cervix. Treatment of cervical laceration. If the bleeding is less, then expectant management will do. But if it is more, then suture can be placed if necessary. Prevention of cervical laceration can be done by preoperative preparation of the cervix with prostaglandin gel or vaginal bisoprost kept 2 hours prior to surgery. If cervical stenosis is encountered and misoprostol has not been used or were not ineffective, as Kuldeep Jain sir has told, that deep intracervical injection of dilute vasopressin at 4 international units can reduce force required for cervical dilatation. In case of previous access failure, adhesion of synecdoche in canal Use of mechanical scissors pass through the operating channel to divide adhesion under direct vision. This video is already shown by the Kuldeep Jain sir. False passage. If you have introduced the telescope and muscle fibers are visible and the tubal ostia are not visible, then assume that the passage is false and slowly remove the hysteroscope and identify the true cavity for confirmation. Discontinue the procedure even if no perforation is detected to prevent fluid from being absorbed into the circulation through the injury. Sinuses can false passage. How to avoid false passage? Dilate cervix with a slow, steady pressure and stop as soon as the internal os is open if you are using dilator, and do not attempt to push the dilator to the uterine fundus. Often the external os opens, but the internal os cannot be dilated, and extra 1 to 2 millimeter dilatation is necessary to accommodate the 27 French resectoscope. So if you are using resectoscope, then extra dilatation is required. How to avoid the creating false passage? Simply turn on resectoscope inflow with the outflow shut off and let the fluid pressure dilate cervix. Always insert hysteroscope or resectoscope under direct vision. Keep dark circle in center, as sir told you, that keep dark circle in the center of the field and slowly advance hysteroscope towards it until cavity is reached. Uterine perforation, incidence of perforation is 14 in per 1000 cases, and it was even higher during the section of lateral and fundal adhesions. Perforation is more common with the thermal energy sources, and it may occur mechanically with dilator or when scissors are used to resect a uterine septum, synecdoche or polyp. So here you can see there is uterine perforation and it can be sutured if there is slight bleeding and you are master in suturing, you can suture the perforated place if it is having bleeding or patient vitals are deteriorating. So uterine perforation predisposing factor are acute anteversion or retroversion of the uterus, cervical stenosis, uterine synecdoche, endometrial malignancy and uterine malformations. Recognition of perforation, loss of uterine distension. Suddenly, once you have perforated the uterus, there will be loss of uterine distension, rapid increase in fluid deficit, and intestinal loop or omentum can be seen. Management of uterine perforation, that procedure should be stopped immediately. If perforation is of small caliber and is not caused by electric current, expectant management treatment will do. Observe for the sign of hemorrhage. If there is tachycardia and hypotension, indicates ongoing hemorrhage. Then you have to go for laparoscopy, stop bleeding by coagulation or sutures. Laparotomy if adjacent organ injury is present. Broad spectrum antibiotic should be given, and hysteroscopy can be repeated after 6 weeks if necessary. Thermal injury prevention, as ma'am told, Punita ma'am has already told that activate foot pedal only when the electrode is moving towards the operator, not towards the fundus. Never activate the device during a forward movement and use roller ball based device at the corner. Intraoperative and postoperative bleeding. It is most common complication and incidence of diffuse hemorrhage is 0.61%. Risk of bleeding is 5 times higher in adhesiolysis, and cervical laceration, perforation, myoma or endometrial resection can also lead to bleeding. It depends on the form of energy used for the resection. With loop and roller ball or loop alone, the incidence is 2.57% and 3.53%. With laser or roller ball, it is 1.17% and 0.97%. Bleeding management, clear the field by opening outflow channel and increase distension pressure above the mean arterial pressure which compresses the uterine wall sufficiently to stop the bleeding. Then bleeding vessel can be coagulated with a 3 mm ball electrode. If distension pressure is relaxed at the end of the procedure and bleeding is still continued, then insert a Foley's balloon into the uterine cavity, inflate it 30 to 50 ml or more for a larger cavity. The balloon is left for 6 to 12 hours. And as madam told, for her submucous myomectomy, you can leave it for 48 hours also. Pack the uterus. If you are not putting Foley's balloon, then you can pack the uterus with the 1/2 inch gauze packet that has been soaked in a dilute vasopressin solution. If this method is also faced, in a very rare cases it happens, when the bleeding is arterial and is controlled by above techniques, is not controlled by above techniques, procedure is abundant and vital sign monitoring should be done, then you can go for uterine artery embolizations if facilities are available, or you can go for hysterectomy. Benefit of vasopressin: before balloon tamponade or packing the uterus, inject very dilute vasopressin directly into the cervix, 2 cm deep at the 4 and 8 o'clock position. So it will reduce the bleeding also. But what is the caution? Always inform your anesthetist about the vasopressin injection, because once it goes in the intravascular vascular space, then it can lead to sudden rise of BP and it can even lead to death of the patient. So it is very important that you are using this vasopressin, then it should be used cautiously. Complication of distension medium: we use a normal saline normally for diagnostic hysteroscopy, and for operative hysteroscopy usually we use glycine 1.5%. Glycine can also be used for diagnostic hysteroscopy as well, and it is used in operative hysteroscopy using mechanical or monopolar resectoscope. Glycine is a simple amino acid that is mixed in water and supplied in 0.5 liter, 1 liter and 3 liter bags. And it is non-electrolytic and hypoosmolar, non-hemolytic and non-immunogenic. So as it is hypoosmolar, so there are more chances of intravascular absorption syndrome. It occurs with electrolyte-free medium, that is, and more in premenopausal women. As Dr. Rana already told you, that estrogen inhibits sodium-potassium ATPase pump, thus water and sodium not thrown out of the cell, and it can lead to neurological complication in premenopausal women. So GnRH agonist inhibits such hormone action and may prevent this complication to occur. Predisposing factor for intravascular absorption syndrome is high intrauterine distension pressure, low mean arterial pressure, deep myometrial penetration, prolonged surgeries, large uterine cavity, provide greater surface area for fluid absorption. Fluid absorption is greater during myomectomies and large diameter endoscopes. When we are using large diameter endoscope, they provide more chances of intravascular absorption syndrome. So once there is absorption, intravascular absorption, that will lead to electrolyte disturbances like hypervolemia, severe hyponatremia, and decreased osmolarity. And it will lead to hazards like right heart failure, pulmonary and cerebral edema, and the incidence and even death. And the incidence of this intravascular absorption syndrome is 0.2 to 2%. Rapid intravascular absorption of glycine through exposed venous sinuses leads to dilutional hyponatremia, acute fluid overload, high blood pressure, reflex bradycardia, cerebral edema, and pulmonary edema. This is followed by hypotension, nausea, vomiting, headache, visual disturbance, agitation, confusion, and lethargy. Glycine is metabolized into ammonia, and higher concentration in the brain decreases the visual acuity in the patient. Glyoxylic acid form oxalate, and glycine is contraindicated in patient with renal impairment. Severity of fluid absorption syndrome depends on the amount of fluid absorbed, number of vascular apertures, duration of procedure, and flow pressure. Symptoms can present intra or post-operatively. Now, the symptoms also depends on the level of sodium. If sodium is at normal level, then management is by observation and fluid restriction. But if the sodium level is 130 to 135 milliequivalent per liter, then mild hyponatremia is there. Patient can have apprehension, disorientation, nausea, vomiting, irritability, twitching, shortness of breath. Treatment is oxygen, furosemide 40 to 60 milligram, and 0.9% normal saline, and catheterization of the patient to strict watch the output. When the level of the sodium is 125 to 130 milliequivalent per liter, then the mild to moderate hyponatremia is there, and urine will be dilute, moist mucous membrane, moist skin, pitting edema may be present, polyuria, and pulmonary rales can be present. Treatment is 3% hypertonic sodium infusion and multidisciplinary involvement. When the sodium level is less than 120 milliequivalent per liter, then it is severe hyponatremia, and the maximum complication will occur at this stage. Hyponatremic encephalopathy, CHF, lethargy, confusion, twitching, focal weakness, convulsions, respiratory arrest, and even death of the patient. Treatment is ICU admission, cardiac echocardiogram, chest X-ray, observe oxygen saturation, urine output, and electrolytes. Closely watch about the potassium and calcium as well. Ventilator support, furosemide IV 1 milligram per kg 4 to 6 hourly, and 3% normal saline, hypertonic saline can be given. 100 ml bolus of 3% saline over 10 minutes, and you can repeat it 3 times. So it's very important to maintain the sodium level. Preoperative prevention is GnRH agonist. It decreases volume of the systemically absorbed distension media, or you can use dilute vasopressin 8 ml injected deeply about 4 and 8 o'clock in the cervix. Prevention before using the resector scope. Baseline serum electrolyte level should be measured. Women with cardiopulmonary disease should be evaluated carefully for shift in the fluid volume. Operating at the lowest effective intrauterine pressure, that is 50 to 80 mmHg, always try to keep this at less than the mean arterial pressure. Completing the procedure as quickly as possible. Measurement of fluid inflow and outflow in a closed system. Precise calculation of the absorbed volume should be done. Bulk vaporizing electrodes reduce systemic absorption compared with the resection loop. Fluid deficit should be calculated frequently. If the deficit reaches a predetermined limit, depending on the patient baseline status, could be 750 to 1500 ml. Serum electrolytes are measured. Furosemide IV 10 to 40 milligram depending on the renal function and termination of the procedure if the fluid deficit is more. Serum sodium decreases to less than 125 milliequivalent per liter if the fluid deficit is 1500 to 2000 ml for the glycine, and the amount of fluid is double for the saline. Normal saline, all of us are using for the, usually we use for the diagnostic purpose, but when you are using bipolar electrode system, then with the bipolar you can use normal saline for operative hysteroscopy as well. So it is safest, widespread availability, low operative cost, and physiological disposal by peritoneal absorption. Excessive vascular absorption lead to fluid overload and pulmonary edema. Normal saline is not suitable for monopolar system because it is a good conductor of electrons. So for monopolar system, the Glycine is a good medium. Air embolism. OT assistant must keep a watch on the fluid bottles and inform surgeon before changing it to prevent entry of air bubble into the uterus. Intracervical injection of vasopressin may block gas from entering circulation. If you are using gas media, although nobody is using nowadays gas media, gases that is CO2, but air embolism can be there. Management, Durant maneuver, left lateral, keep patient left lateral with the head low position with Trendelenburg position. 100% oxygen should be given. CVC insertion or direct needle in the right atrium to remove the air, and patient may require CPR. Now come to the late onset complication of hysteroscopy. The late onset complication include infection. To avoid hysteroscopy, we should avoid hysteroscopy in gross cervical infection, uterine infection, and salpingitis. Role of antibiotics are controversial in routine use, but antibiotics should be used in cases with RHD, CHD, suspected chronic endometritis, submucous myomas procedure, and MDID IUDs removal. ACOG guidelines do not recommend routine prophylactic antibiotic for hysteroscopy. Vaginal discharge are very common and in any ablative procedure and is usually self-limiting. Hematometra occurs if obstruction of the internal os secondary to adhesion due to hysteroscopy surgery. Isthmus region and cervical canal should be avoided during resection. Adhesion formation. Intrauterine adhesions are common, especially after myomectomy, when two fibroids are situated on opposing uterine wall, after lysis of intrauterine adhesion and excessive endometrial resection. Prevention, cyclic hormone tablets to facilitate growth of the endometrium and insertion of IUCD. Conclusion. Hysteroscopy surgery is safe and effective. Specific risks due to distension media and surgical technologies used, and more chances of fluid overload occur with the glycine. So to minimize the risk of complication, appropriate case selection, recognition of the learning phase, patient and surgical team preparation, knowledge of distension media use, and knowledge of hysteroscopic equipment use is must for successful hysteroscopy. Thank you for your patient listening. Thank you so much.
Thank you, Padma ma'am. Sagar sir, would you like to give some remarks on lecture of Padma ma'am?
Dr. Padma, you have nicely narrated the complications of hysteroscopy and their management. And definitely, automated fluid management system will be better to counteract the fluid deficit. Though there are few rare major complications like uterine perforation or fluid overload, in view of the positive outcomes to the risk, it is a worth one. So thanks for your enlightening speech.
Thank you, sir. Thank you so much.
Ma'am, Priyanka ma'am, question from chat box.
Very nice presentation by Dr. Padma as usual. Dr. Padma, Dr. Preeti Gupta wants to know which fluid is better for operative hysteroscopy.
Glycine is better when monopolar system is being used, and glycine is better fluid. But we have to keep a strict watch on the input and output flow so that there should be no fluid absorption syndrome. If we are using bipolar system, then normal saline is the better. So if it depends on your training and the system which you are using. So now, usually we use glycine for all operative procedure, and normal saline is being used for diagnostic procedures. So for diagnostic, everyone is using, I think, normal saline, and that is the fluid of choice. And for operative purposes, glycine is the fluid of choice.
Okay. Thank you, Dr. Padma. One more question. Dr. Payal wants to know which route is better for vasopressin.
Which route is better for vasopressin? It is given intracervical.
Okay.
Intracervical route is given, although it is in diluted form. You cannot, because vasopressin, it lead to hypertension once the vasopressin goes in the intravascular space. So we should use in intracervical at 4 and 8 o'clock position. You have to insert and you have to withdraw before injecting, so that there should be no injection inside the intravascular
compartment.
Yeah.
And one more question, Dr. Padma. Dr. Giren want to know how long should we wait before attempting pregnancy?
How long we should wait?
Before attempting pregnancy.
Before attempting pregnancy. As madam told that patient, if there is no, during adhesiolysis, definitely it is problem.
This question has already discussed by
there, then we have to give. This is already discussed already.
Already.
But, after
Dr. Priyanka,
adhesiolysis,
all questions
has to wait for 2 months. Otherwise, after like mammectomy, as madam told, that she can go for pregnancy as her menses comes.
Thank you, Dr. Padma.